Hello everyone, I am myself Dr. Rajesh Gubba. I'm the general medicine educator. I'll be discussing a very important form of vasculitis in this session, that is the giant cell arteritis. So, giant cell arteritis, it is a form of large vessel vasculitis. Right? It is a form of the large vessel vasculitis. And in these patients with the giant cell arteritis, the most common vessel which is affected is the temporal artery. And that is the reason why this is called as, right? That is the reason why this is called as temporal arteritis. Alright? And this giant cell arteritis, it is most commonly seen in adults, right? Of age group more than 50 years. Right? In age group more than 50 years, this giant cell arteritis is very commonly seen. And let me tell you, the most common form of vasculitis in adults, right? Most common form of vasculitis in adults, that is idiopathic cutaneous vasculitis. Right? Idiopathic cutaneous vasculitis. That is the most common form of vasculitis in adults. And after this idiopathic cutaneous vasculitis, the next most common cause for vasculitis in adults will be giant cell arteritis. So giant cell arteritis, it is the second most common cause of the vasculitis. Right? It is the second most common cause of vasculitis in adults. And the type of inflammation, if you observe in giant cell arteritis, it is granulomatous inflammation. Right? It is the granulomatous inflammation. And in case of this giant cell arteritis, it is the large vessels which are commonly affected. And not only large vessels, the other vessels which are affected in case of the giant cell arteritis is even the medium vessels are also affected in case of the giant cell arteritis. And the most common vessel, it is the temporal artery, right? This temporal artery, let me tell you, it is the extracranial branch of the carotid artery. So, if you see the most common vessel which is affected, it is extracranial branch of the carotid artery. So, this extracranial branch of the carotid artery, especially the superficial temporal artery, right? Especially the superficial temporal artery is the one which is most commonly affected in this giant cell arteritis, and that is the reason why it is called temporal arteritis. That is the reason why it is called temporal arteritis. Now, apart from the temporal artery, the other vessels which are affected in case of the giant cell arteritis, it includes vertebral artery, next ophthalmic artery, and the aorta. So these are the vessels which are commonly affected in case of the giant cell arteritis. Next to your temporal artery involvement. So if you take the aortic involvement, where it may cause thoracic aneurysm, right, where it may cause the thoracic aneurysm. These are the vessels which are affected in patients with the giant cell arteritis. Now, and I said you the most common vessel affected is the temporal artery, right? This temporal artery, let me tell you, on palpation, right, when you palpate the temporal artery, it is either nodular, right, and it is enlarged, and let me tell you, it is tender on palpation, right? It is tender on palpation. That is what is your temporal artery, right? It is nodular, enlarged, and tender on palpation, right? And sometimes, it can be normal on physical examination also. That is what is the appearance of the temporal artery on palpation. And if you see male to female ratio, this giant cell arteritis, it is most commonly seen in women, right? Most commonly seen in women rather than men. And in which group of individuals you see this very commonly? This is more common in whites than blacks, right? This is more common in whites rather than blacks. And what are the vessels which are affected? Preferentially, it affects the extracranial branches of the external carotid artery. So, if you take the temporal artery, it is a branch of right, it is a branch of the external carotid artery, right? That is what is your temporal artery. Okay, now these patients with the giant cell arteritis, what will be the most common symptom? Most common symptom, it is headache, right? Most common symptom will be headache, and along with that there will be also development of the constitutional symptoms. And these constitutional symptoms, right, these constitutional symptoms, they include malaise, fatigue, loss of appetite, and even weight loss. So these are the constitutional symptoms that can be seen. And apart from that, even the development of fever, right? Development of fever, it is seen in almost 40% of patients. So these are the constitutional symptoms, but the most common symptom will be the headache. Okay. So if you see this particular headache, it is most commonly localized over the temporal region. Right? It is most commonly localized over the temporal region. And the character of the headache, if you see, it is described as dull aching pain. Right? It is described as dull aching pain. And this headache, it is often associated with scalp tenderness. Right? When you palpate over the temporal artery, there is a chance that these individuals will have the pain. Right? And this particular headache, it is mostly unilateral. Right? It can be bilateral also, but mostly unilateral. And this particular, I was discussing about the scalp tenderness. So these patients with the temporal arteritis or giant cell arteritis, they have pain in the scalp when they comb or brush. Right? They have pain in the scalp, right, when they comb or when they brush their hair with some paints and all, right? And let me tell you, and it is mostly localized, right? It is mostly localized where the pain is mostly localized exactly over the, right, exactly over the temporal artery. And temporal artery already I have discussed, it is thick and as well as nodular. So this will be the description about the headache. So most common symptom is headache, most commonly localized over the temporal region. Typically it is described as dull aching pain and it is often associated with scalp tenderness. So whenever the patient combs or brushes their hair, these patients, they can feel that particular tenderness. And another important symptom is the jaw claudication. So this is also the most specific symptom, right? And these patients, they complain of pain in the masseter muscle. Right? They complain of pain in the masseter muscle. Okay? And this particular pain, it increases on chewing. Right? This particular pain increases on chewing. That is what is your jaw claudication. That is what is your jaw claudication, where the pain increases within the jaw, right, upon the prolonged chewing. Next, followed by that, let me tell you, there is also involvement of the ophthalmic artery in these individuals. Most common symptom already we have discussed, that is headache, no doubt in that. But these patients, they also have the visual loss. And why is this particular visual loss present in this individual? Visual loss is usually caused by occlusion of posterior ciliary branch of ophthalmic artery. Okay, it is caused by occlusion of posterior ciliary branch of ophthalmic artery. Because of the involvement of this particular vessel, there is development of the visual loss, right? And that we call it as anterior ischemic optic neuropathy. Right? That we call it as anterior ischemic optic neuropathy. So that is what is your the visual loss that you will have in patients with the giant cell arteritis. And the risk of blindness, right? The risk of blindness, it correlates with high levels of interleukin 6. Right? Risk of blindness, it correlates with high levels of the interleukin 6. So more is your interleukin 6, greater is the chance of development of the visual loss. And the other visual manifestations, that includes diplopia. Okay, so diplopia is other most common visual symptom next to your visual loss. So visual loss, you know, it is the most feared complication of giant cell arteritis. Why am I telling it is a most feared complication? Because this visual loss, right? Because this visual loss, it is irreversible. That is the reason why it is considered as the most feared complication. Then, followed by that, next important association of giant cell arteritis is polymyalgia rheumatica. So we have discussed symptoms due to vasculitis, right? That is temporal artery involvement and as well as ophthalmic artery involvement. And let me tell you, in almost 40% of patients with the giant cell arteritis, right, in almost 40% of patients with giant cell arteritis, they also present with symptoms of the polymyalgia rheumatica, right? And what will be the features of polymyalgia rheumatica? That includes pain and stiffness in the neck, shoulder and hip girdle. Okay, pain and stiffness in the neck, shoulder right, pain and stiffness in the neck, shoulder and as well as the hip girdle. And this particular pain and as well as stiffness, they are much worse in the morning. Right, they are much worse in the morning. And these patients, they complain of difficulty in getting out of the bed. Right, they complain of difficulty right, they complain of difficulty in getting out of the bed, and they complain of difficulty in arising or getting up from the toilet, and they have even difficulty in brushing their teeth. And among this particular shoulder and as well as the hip girdle, let me tell you, it is your shoulder which is commonly affected then compared to that of the hip girdle, right, then compared to that of your hip girdle. So that is about the features of the polymyalgia rheumatica. So polymyalgia rheumatica, let me tell you, the association in giant cell arteritis is almost nearly 40%. Nearly 40% of patients of giant cell arteritis, they present with these features of the polymyalgia rheumatica. Right? Then, this polymyalgia rheumatica and as well as the giant cell arteritis, what is the basic difference? The important differences between the two conditions are that polymyalgia rheumatica alone does not cause blindness. Okay, polymyalgia rheumatica alone, there is no blindness, right, in case of polymyalgia rheumatica alone. And these patients with polymyalgia rheumatica, they respond to low dose steroids. Right, they respond to your low dose steroids. Okay, and the dosage is around 10 to 20 milligrams per day orally. Right, 10 to 20 milligrams per day orally. That is the treatment for your polymyalgia rheumatica. Right, and that particular steroids, it includes the prednisolone therapy. Right, it includes the prednisolone therapy. Okay, whereas you take giant cell arteritis, we have discussed that will cause blindness. And in case of giant cell arteritis, you require high dose steroids compared to that of the polymyalgia rheumatica. And the dosage of prednisolone in case of giant cell arteritis, it is around 40 to 60 milligrams per day. Right, that is what is the treatment for giant cell arteritis. Now, what is the criteria? Right, what is the criteria for polymyalgia rheumatica? See, the criteria for polymyalgia rheumatica is that first and foremost, the stiffness. Right, that is the stiff. Okay, and before that, let me discuss the age. Age of the individual with polymyalgia rheumatica should be of more than 50 years. And next thing is the stiffness, aching and stiffness for at least 1 month. Right, aching and stiffness should be there for at least 1 month. Right, and where should be this aching and stiffness? That is in the shoulder, neck and as well as in the hip girdle. And this stiffness should be more commonly in the morning. Right, that is morning stiffness. and this stiffness should be there for more than 1 hour, right? Should be there at least for more than 1 hour. And even if you observe the ESR, that is erythrocyte sedimentation rate, that should be more than 40 millimeters per hour. And there should be a rapid response to prednisolone. Right? There should be a rapid response to prednisolone. So that is the criteria of polymyalgia rheumatica. Now, followed by that, if you take the criteria of the giant cell arteritis. See, criteria of giant cell arteritis is slightly different from the criteria of the polymyalgia rheumatica. That includes the age of the individual, same, more than 50 years, right? And the clinical feature in these patients with giant cell arteritis is, it is the development of new onset headache. Right, it is the development of new onset headache, and there should be abnormal temporal artery, and ESR of the individual, it is more than 50 millimeters per hour. And fifth important point is positive temporal artery biopsy, right? Temporal artery biopsy, right? Temporal artery biopsy, that should show the presence of the granulomatous inflammation. Right, that should show the presence of granulomatous inflammation. So that is what is the criteria of the giant cell arteritis. Okay. Now, out of these criteria, right, totally 5 criteria are there. Out of this, 3 out of 5, they are required for the diagnosis of the giant cell arteritis. Right, 3 out of 5 are required for the diagnosis of giant cell arteritis. So, if you see the summary of the giant cell arteritis, they'll have the features of vasculitis, right? Temporal artery involvement will cause the development of headache, and ophthalmic artery involvement will cause the visual loss or blindness. And there will be also features of the polymyalgia rheumatica, right? Which is seen in 40% of patients. Pain and stiffness can be there in the neck, shoulder, and as well as in the hip. So these are the features of the giant cell arteritis, right? This is a summary of the features of the giant cell arteritis. Now let me discuss the investigations in patients with the giant cell arteritis. So all of the following are true about temporal arteritis except polymyalgia rheumatica, anemia, low ESR, sudden blindness. Polymyalgia rheumatica we have seen, it is seen in almost 40% of individuals. Sudden onset blindness can also be there, right? That is because of the involvement of ophthalmic artery, right? That is because of the involvement of ophthalmic artery. Anemia can also be there, that is anemia of chronic inflammation. But low ESR, that is not the feature of the temporal arteritis. These patients with the temporal arteritis, they have the high ESR. Now, let me discuss the laboratory findings. In case of polymyalgia rheumatica, there will be presence of anemia, right? Anemia of chronic inflammation. And there will be also elevated acute phase reactants. Right, there will be elevated acute phase reactants. That is, there will be elevated ESR, right? And ESR, it is more than 30 millimeters per hour. And CRP, that is C-reactive protein, it should be more than 0.5 milligrams per deciliter. right? It should be more than 0.5 milligrams per deciliter. So this is what is present in most of the cases. In case of giant cell arteritis, nearly 90% of patients with giant cell arteritis, they have the ESR more than 50 millimeters per hour. Right, more than 50 millimeters per hour. That is what you will see in case of giant cell arteritis. Whereas in case of polymyalgia rheumatica, it is more than 30 millimeters per hour. And if you take the complete blood picture in patients with the giant cell arteritis, they have normocytic normochromic anemia. Right, normocytic normochromic anemia. That is what is the complete blood picture in patients with the giant cell arteritis, and there can be also development of thrombocytosis. That is what is the complete blood picture in patients with the giant cell arteritis. And if you see the alkaline phosphatase levels, they are elevated. And what is the source of this alkaline phosphatase? See, the alkaline phosphatase source, it can be from bone, it can be from liver, it can be from placenta. But here in giant cell arteritis, it is from the liver. Right, it is from the liver. Okay, and the alkaline phosphatase levels is elevated in 20% of patients. Right, it is elevated in 20% of patients with giant cell arteritis. Okay, next, very important investigation, that is gold standard investigation or investigation of choice will be temporal artery biopsy. Right, temporal artery biopsy should be done as soon as possible when the clinical picture is suggestive of the temporal arteritis. Now, what do you understand by the terminology positive biopsy? Right, what do you understand by the terminology positive biopsy? Positive biopsy, it shows inflammatory infiltrate in the media. Right, inflammatory infiltrate in the tunica media. Right, inflammatory infiltrate in the tunica media and as well as adventitia. Right, as well as the adventitia. So we have three layers in the blood vessel, that is tunica intima, media and adventitia. So this inflammatory infiltrate, it is present in the tunica media and adventitia. And what does this inflammatory infiltrate contain? It contains the lymphocytes. Right, it contains the histiocytes. Right, it contains the presence of plasma cells. It contains the presence of the giant cells. So this is what is the inflammatory infiltrate in patients with the giant cell arteritis being present. And whenever you are taking a biopsy, an adequate biopsy specimen is essential. Right, adequate biopsy specimen is very much essential. And how much is that adequate biopsy specimen? It should be at least 2 centimeters in length, that is ideal. Right, that is 2 centimeters in length, that is ideal. Now, why is that we have to take 2 centimeters in length? Because the disease is segmental. Right, because the disease is segmental. And that is the reason why you have to take an at least 2 centimeters length of the temporal artery, right? And when you are doing a unilateral temporal artery biopsy, right? Unilateral temporal artery biopsy, they are positive in approximately 80 to 85% of patients, right? But bilateral biopsies add incrementally to the yield, right? So if you do bilateral biopsies, that will add incrementally to the yield. So that is about your temporal artery biopsy. And even this temporal artery biopsy is abnormal only in 50% of patients. Right? It is abnormal only in 50% of patients. Okay? And when you do, so this is about your investigation of choice. And when you do a temporal artery ultrasonography will show you the presence of what is called the halo sign. Right? The temporal artery biopsy will show you the presence of the halo sign. Okay? And when there is presence of the halo sign on temporal artery ultrasonography, this will obviate the need for temporal artery biopsy. Right? Definitely, the biopsy remains the gold standard for giant cell artery diagnosis. But the presence of halo sign on temporal artery ultrasonography will obviate the need for the temporal artery biopsy. Then, now let us discuss the treatment. So, gold standard investigation is temporal artery biopsy. How much you have to take? 2 centimeters, because it is like the temporal arteritis, it is segmental. And what does the inflammatory infiltrate contain? The inflammatory infiltrate, they contain the cells, and these particular cells, they are deposited in the media and as well as adventitia. They include lymphocytes, histiocytes, basophils, and as well as the giant cells. Then, if you see the treatment in patients with the giant cell arteritis, so first of all, you take the treatment in polymyalgia rheumatica. I said you 40% of patients with giant cell arteritis, they have this associated polymyalgia rheumatica. So in patients who have only isolated polymyalgia rheumatica, that means what? Those not having above the neck symptoms, like there is no headache, there is no jaw claudication, there is no scalp tenderness, and there is no visual symptoms also. These patients, they have to be treated with prednisolone. So the dosage of prednisolone in case of the polymyalgia rheumatica, it is around 10 to 20, right? It is around 10 to 20 milligrams per day orally. Right? It is the oral route of administration. And but suppose you are giving this 10 to 20 milligrams per day orally. If the patient does not experience a dramatic improvement within 72 hours, the diagnosis should be revised. Okay, so right, if there is no improvement in 72 hours, then the diagnosis has to be revised. And usually after 2 to 4 weeks of treatment, slow tapering of prednisolone can be attempted. Right, after 2 to 4 weeks of treatment, right, slow tapering of prednisolone can be attempted. Right, so this is about the treatment of the polymyalgia rheumatica. And for how many days you will give this prednisolone? Most patients, they require some dose of prednisolone for a minimum of approximately 1 year. Right, for a minimum of approximately 1 year of prednisolone should be given. If you give 6 months, it is too short in most cases. right? But only thing is, when you are giving corticosteroids for nearly around 1 year, care must be taken to prevent adverse effects of steroids. There are multiple adverse effects associated with steroids, like osteoporosis, proximal myopathy, development of peptic ulcer, development of the iatrogenic Cushing syndrome. So this care should be taken to prevent the adverse effects of the corticosteroids, right? And the disease flares are common as prednisolone is tapered. So whenever you are tapering these particular steroids, right, the disease flares are common. Right, the disease flares are common, right? That is seen in almost like more than 50% of individuals. The disease flares are very common. And whenever the disease flares are common during the tapering of the steroids, this requires increasing in the dose of prednisolone. Right, this requires increasing in the dosage of the prednisolone. Okay, so that is about the duration of the treatment of the polymyalgia rheumatica. And one more important point you should remember key, whenever you are tapering the prednisolone, right, tapering of the prednisolone should be based on the symptoms, right? So tapering should be based on tapering of the prednisolone should be based on the symptoms, but not on laboratory values. Not on laboratory values. Why? Because whenever you are tapering these particular steroids, ESR can fluctuate. Right? The ESR can fluctuate. And it is not specific for polymyalgia rheumatica disease activity. So when ESR is fluctuating, that doesn't tell you about the polymyalgia rheumatica disease activity. So tapering of steroids should be based on the symptoms, not on the ESR. And to this particular steroids, addition of weekly methotrexate may increase the chance of successfully tapering the prednisolone. So this combination, it is helpful in successfully tapering the prednisolone in some patients whenever you add methotrexate to this particular steroid. So that is about the treatment of polymyalgia rheumatica. So what is it different in the treatment of giant cell arteritis? The dosage of prednisolone. It is around only 10 to 20 milligrams, which is required per day. And this particular 10 to 20 milligrams you have to give for nearly around 1 year. Right? Short duration, 6 months, usually it is not advisable. Right? 10 to 20 milligrams per day. And if the patient does not experience dramatic improvement within 72 hours, the diagnosis has to be revised. And usually after 2 to 4 weeks of treatment, slow tapering of prednisolone that can be attempted, right? And the duration is around 1 year. But only thing is, whenever you are giving steroids for up to 1 year, you have to take care of the adverse effects, right? And whenever you are tapering the steroids, the disease flares are common, and that may necessitate the increasing in the dosage of the prednisolone. And whenever you are tapering the prednisolone, that should be purely based on the symptomatology, not on the laboratory values, because the ESR can fluctuate whenever you are tapering these particular steroids. And whenever you add methotrexate to these particular steroids, that may increase the chance of successfully tapering the prednisolone in some patients. Now, coming to the treatment of giant cell arteritis. See, why this giant cell arteritis is very important is, the urgency of early diagnosis and treatment in giant cell arteritis relates to the prevention of blindness. So, most feared complication here is blindness. Because blindness, once the individual develops, it is irreversible. It is permanent. So, early diagnosis and quick starting of your steroids is very much required. Right? And what should be the dosage of? Right? What should be the dosage of prednisolone here? That is around 1 milligram per kg daily. Okay? Or 60 milligrams per day. Right? Or 60 milligrams per day orally should be initiated immediately. Right? Even after starting prednisolone also, you can take temporal artery biopsy. See, please don't wait for temporal artery biopsy. Please don't wait for temporal artery biopsy report. Even after starting prednisolone, the temporal artery biopsy, it is performed. Right? You will not have any problem. Right? You will not have any problem in the diagnosis of your temporal artery biopsy. Right? And for patients, so what are we very much worried about? We are very much worried about the blindness. So, in individuals who has developed blindness, the drug that can be given is intravenous pulse methylprednisolone. Okay, this example, right, what should be the dosage of your intravenous pulse methylprednisolone? That should be 1 gram daily for 3 days. Right, 1 gram daily for 3 days. This has been advocated. Right, and few patients, they recover vision, and few, they may not recover the vision. Right, and it is very important to start these particular steroids before taking the temporal artery biopsy. Once you have diagnosed clinically that it is temporal arteritis, start these particular steroids. And you may be under the impression that whenever you start the treatment, the features of the granulomatous inflammation may disappear. It is not like that. So, the features of granulomatous inflammation may still be present up to 2 weeks after starting the steroids. Right, the features of the giant cell arteritis within the vessel may be present even 2 weeks after starting the corticosteroids. And what is the features of your giant cell arteritis in the biopsy? There will be presence of the inflammatory infiltrate in the media and as well as adventitia, where there will be the infiltration of lymphocytes, infiltration of the histiocytes, infiltration of the plasma cells, and infiltration of the giant cells. And you need to take a biopsy specimen of up to 2 centimeters. Right, 2 centimeters in length is ideal because the disease may be segmental. And unilateral biopsies, they are positive in approximately 80 to 85% of patients. But bilateral biopsies, they add incrementally to the yield. And what is that ultrasonography shows? The presence of the halocene. Right, the presence of the halocene. Okay, that is the ultrasonography picture in patients with giant cell arteritis. Now, in these patients with the giant cell arteritis, you also, the development of aneurysms in the aorta is also very important in this. Okay, so now you see the aneurysms. Temporal artery biopsy, as already I have said you, it is abnormal in only 50% of patients with large artery giant cell arteritis. So in large artery giant cell arteritis, in these patients, magnetic resonance angiography or CT angiography that will establish the diagnosis by demonstrating the long stretches of narrowing, thickening or aneurysmal dilatation of the aorta. So in case of large artery giant cell arteritis, there can be development of the aneurysm, right? There can be development of the aneurysm, and these aneurysms, right, they are very common in the aorta, right? They are very common in the subclavian artery, right? They are also very common, right? They are also very common in the axillary artery, and out of which the thoracic aortic aneurysms, right, out of which the thoracic aortic aneurysms, they occur 17 times more frequently in patients with giant cell arteritis than in the normal individuals. And because of this thoracic aortic aneurysms, the individual can have the development of the aortic regurgitation, right? The individual can have the development of aortic regurgitation. And because of this thoracic aortic aneurysms, there can be also development of aortic dissection. There can be also development of the aortic rupture. That is what you will see in case of the thoracic aortic. Because of thoracic aortic aneurysms, these all will be the consequences. These all will be the consequences. And the aneurysms can develop at any time, but typically they occur 7 years after the diagnosis of the giant cell arteritis. So these aneurysms, they develop almost 7 years after the diagnosis of giant cell arteritis is made. So that is the reason why you have to do routine screening for this complication, right? So routine screening, okay, routine screening of this complication is very much recommended, okay? And what is the dosage of the prednisolone if the aneurysms have developed? Prednisolone should be continued in a dosage of 60 mg per day orally for about 1 month before tapering, right? So the dosage should be right, the dosage should be 60 milligrams per day orally, right, orally for about 1 month, right, for about 1 month before tapering. After 1 month of high dose prednisolone, almost all patients will have the normal ESR, right? Almost all patients will have the normal ESR, okay? And you have to keep in mind that while tapering and adjusting the dosage of prednisolone, the ESR is useful, but not an absolute guide to the disease activity. See, a common error what we do is we try to treat the ESR, not the patient. That should not be the way you have to treat, right? You have to treat the patient's symptomatology, not the laboratory report ESR. ESR, it often rises slightly as the prednisolone is tapered. So, whenever you are tapering the prednisolone, ESR can slightly increase. Even though the disease is like quiescent, the ESR may slightly rise whenever you are tapering this particular prednisolone, okay? And because this is the disease of elderly individual, right? Elderly individuals often, they have baseline ESRs that are above the normal range, right? Baseline ESR in elderly individuals, they are above the normal range. And mild ESR elevations should not be an occasion for renewed treatment with prednisolone in patients who are asymptomatic. Right? In those patients who are asymptomatic, because there is mild ESR elevation, you should not again restart the prednisolone from the starting dose. Right? Don't do that. Next, apart from this prednisolone, we have another inhibitor of interleukin 6 receptor. Right? And that particular inhibitor of the interleukin 6 is tocilizumab. Right? What is this? It is an inhibitor of it is an inhibitor of the interleukin 6 receptor, right? And this is FDA approved drug for giant cell arteritis. Okay, it is an FDA approved drug for the treatment of giant cell arteritis. And this tocilizumab can reduce the prolonged usage of the prednisolone. The advantage is that this will reduce prolonged use of the steroids, and because of which the adverse effects which are associated with the steroids can be reduced, right? That is the advantage of this particular tocilizumab being added, right? And clinical trials demonstrate that patients with new or relapsing giant cell arteritis with cranial or large vessel involvement treated with both tocilizumab and prednisolone can taper off prednisolone more rapidly and successfully than patients treated with prednisolone alone, right? So what does the clinical trial show? It shows that when you are adding tocilizumab to the steroids, in case of new onset giant cell arteritis or in a relapse case of giant cell arteritis, in these individuals, when you are giving these drugs in combination, they can taper off prednisolone, right? You can taper off the prednisolone rapidly and early rather than giving the prednisolone alone. Okay, that is the advantage of this particular combination, right? And after 1 year of treatment, tocilizumab achieves corticosteroid free remission in approximately 50% of patients. So almost after 1 year of treatment, tocilizumab, it achieves corticosteroid free remission. Right, corticosteroid free remission in almost 50% of patients. And on the other hand, methotrexate, it has been less promising, and it was modestly effective in one double-blind placebo-controlled treatment trial, but ineffective in other studies. So methotrexate, it is less promising in the treatment of giant cell arteritis. So along with steroids, tocilizumab is another add-on agent. So that completes the treatment of your giant cell arteritis. Let me just do a quick recap on the treatment part, which is very important. In case of polymyalgia rheumatica, that means the patient is having only polymyalgia rheumatica. In that case, the dosage of steroid is only 10 to 20 milligrams per day, that too orally. And there should be a dramatic improvement within 72 hours. If there is no dramatic improvement, the diagnosis should be revised. And usually after 2 to 4 weeks, slow tapering of the prednisolone that can be attempted. And the duration of the steroids is up to 1 year. 6 months is too short in most of the cases. But only thing is, whenever you are giving 1 year of steroids, care must be taken to prevent the corticosteroid side effects. And the disease flares are common as prednisolone is tapered. Whenever you are tapering the prednisolone, there is chance of disease flares. In such case, you need to increase the dosage of the prednisolone, right? And tapering of prednisolone should be based on symptoms and not solely on laboratory values, because the ESR, it can fluctuate and it is not specific for polymyalgia rheumatica disease activity, right? And the addition of weekly methotrexate may increase the chance of successfully tapering the prednisolone in some patients. In polymyalgia rheumatica, you add methotrexate to steroids. In giant cell arteritis, you need to add tocilizumab to your steroids. So in giant cell arteritis, the dosage of your prednisolone, it is around 30 to 60 milligrams per day, right? Or in individual who has developed the blindness, pulse methyl prednisolone of 1 gram daily for 3 days has been advocated. And in some patients, there was recovery of this particular blindness also. And you have to start the treatment immediately in giant cell arteritis. Why? Because of the risk of this blindness. Even after starting treatment also, up to 2 weeks, you will have that inflammation within the giant cell artery. Even if you take the biopsy, even after 2 weeks, up to 2 weeks, you can have this particular features of the granulomatous inflammation within the giant cell artery. And whenever you do temporal artery ultrasonography, there will be presence of the halo sign, right? There will be presence of the halo sign. And next thing is, when you do, or when in patients with large artery giant cell arteritis, large artery in the sense, like you take aorta, there can be development of aneurysms. You know, in patients with giant cell arteritis, thoracic aortic aneurysms occur 17 times more frequently in patients with giant cell arteritis. Okay, and how will you diagnose this, the aneurysms? That is by magnetic resonance angiography or the CT angiography. But these aneurysms can develop at any time, but typically occur 7 years after the diagnosis of giant cell arteritis is made. Hence, routine screening for this complication is very much recommended, right? And you have to give 60 milligrams per day orally of prednisolone for about 1 month. You have to give, and then you have to slowly taper. And tapering is again completely dependent on the clinical manifestation, not on the ESR, because ESR can fluctuate whenever you are tapering this particular steroids. And to this particular steroids, when you add this tocilizumab, the chance of, or the prednisolone can be tapered early than compared to that of 1 year of treatment of the prednisolone, right? And after almost like 1 year of treatment, the individual will become completely corticosteroid free. Methotrexate, it doesn't have much effect in case of the giant cell arteritis. So, if you see some questions on the topic of giant cell arteritis, the question is, a 50-year-old male came to emergency department with complaining of unilateral weakness, diplopia, and difficulty in chewing. On evaluation, MRI was normal, right? But the ESR was persistently high. The most appropriate drug for the treatment: aspirin, coxips, prednisolone, sodium valproate. So what is that you have to give in this individual? You have to give prednisolone, because this is a case of the giant cell arteritis. This is a case of giant cell arteritis. And how can you say that? Unilateral headache, diplopia, difficulty in chewing, that is jaw claudication. MRI is normal because it is not a large vessel giant cell arteritis. Large vessel giant cell arteritis, there is chance of development of thoracic aortic aneurysms, right? ESR being persistently high is another point in favor that these patients, they require prednisolone as a treatment. Then is there any role of your aspirin in patients with giant cell arteritis? Yes. Low dose aspirin, right? Low dose aspirin is added to the therapy in order to reduce, right? This will reduce the risk of blindness. Right? This will reduce the risk of blindness. And this will also reduce the risk of transient ischemic attack. This will also reduce the risk of stroke. Okay? That is the advantage of adding the low dose aspirin. Right? And another important question. All are true about giant cell arteritis or temporal arteritis except can lead to sudden bilateral blindness, most common in females, worsens on exposure to heat, most affect elderly individual. So, can lead to sudden onset bilateral blindness, it is true statement. And that is due to involvement of posterior ciliary branch of ophthalmic artery, and it is more common in females rather than males. Most commonly affects elderly individuals beyond 50 years and worsens on exposure to heat is a wrong statement, right? This worsens on exposure to cold, right? This worsens on exposure to cold, right? Next, then followed by that, let me discuss or let me tell you about this particular headache. Most common cause of headache, if you see or if the question is asked, the answer is the tension headache. And what is the most common cause of secondary headache? That will be infections. And what is the most common cause of pulsatile headache? That is migraine. Most common cause of temporal headache? Giant cell arteritis. Most common cause of occipital headache? That is hypertension. Then followed by that, basilar migraine. Right, so these are the causes. These are like, some most common causes for headaches of various varieties. So this completes the discussion of this very, very important topic, giant cell arteritis. So what is the criteria for giant cell arteritis? Age should be more than 50 years. Headache, that is very, very important. Mostly unilateral headache, new-onset headache, and abnormal temporal artery, and granulomatous inflammation within the temporal artery, and a very good response to your prednisone. So this is the criteria for your temporal arteritis, and in almost 40% of individuals, they have the associated polymyalgia rheumatica. And in both of them, either you take polymyalgia rheumatica or giant cell arteritis, the treatment is same prednisone, but the only difference is the dosages, right? So this completes the discussion of this very important topic, that is giant cell arteritis. Thank you very much.